Bună dimineața. My name is Dr. Nathan Wong from the University of California, Irvine in the United States. It's my real pleasure and honor to be a visiting professor here at the Victor Babeș University of Timisoara in Romania. I've enjoyed my actually second visit now to Romania to see your beautiful city of actually Timisoara. Everyone has been extremely friendly to me here, and I'm extremely grateful to be hosted by actually Dr. Dan Gaita, my close friend and colleague involved with preventive cardiology, who has really been the leader here in Romania in the area of preventive and rehabilitative cardiology. So I've been very, very impressed to see this university's commitment to promoting cardiovascular health and preventive cardiology, and to you know, the real passion that actually Dr. Gaita has in actually promoting various aspects of cardiovascular health and prevention throughout the world. Today I'm going to be discussing important aspects in cardiovascular risk assessment, which is really the foundation of preventive cardiology. It's very important that we assess our patient's risk to appropriately target the intensity of therapeutic interventions. So what I'll be discussing is going over the row of what we call global risk assessment, covering the different types of scoring systems that we have for actually estimating a patient's cardiovascular risk. Then followed by discussing a row that perhaps some of the newer biomarkers and actually novel risk factors may have in further refining our ability to predict cardiovascular disease. Finally, realizing that many patients who eventually suffer cardiovascular events may not necessarily have many of the classic risk factors. We're actually going to be discussing the role of subclinical atherosclerosis screening, including certain modalities such as carotid ultrasound, ankle-brachial index, and finally coronary calcium, and how these different modalities can be used to further refine a patient's risk and to determine really who is most likely to benefit from therapeutic strategies. I think it's fantastic to see all the progress that actually Romania has made, in part due to Dr. Gaita's leadership in the area of preventive cardiology. And I certainly look forward to following the progress that Romania as a whole, and in particular the actually Victor Babeș University of Timisoara will be making in the next few years as you continue to further develop your preventive as well as cardiac rehabilitative programs here. It's very important that we realize that screening for atherosclerosis isn't necessarily meant for the entire population. Most of our practice guidelines recommend that we start with actually global risk scoring to get an initial estimate of a patient's risk. And then really the important question is that if you're going to do one of these screening modalities, coronary calcium certainly has probably the strongest evidence to improve cardiovascular risk assessment beyond standard risk factors, but there are also other modalities such as carotid ultrasound, including looking at echolucent plaques, as well as ankle-brachial index, even some lesser established modalities such as pulse wave analysis, and fingertip tonometry is able to look, for example, at endothelial function. But when you're considering one of these tests, which have been generally recommended for what we call a patient who is at intermediate risk, it's the number one question you have to ask yourself, is it dependent on the results of the test? Is it going to change how you manage the patient? Because if the patient is already at high risk, for example, and recommended for intensive therapy, such as a secondary prevention patient, then these tests, for example, would not be recommended in that type of patient because the results are not likely to change how you treat the patient. Now, some studies, though, have shown, for example, that if the patient actually sees, for example, the calcium deposits in their arteries from a coronary calcium scan, that may really help to better motivate them to follow their doctor's orders, say to follow a statin or to, lose weight or perhaps exercise more. So again, there certainly is truth to the concept that a picture is worth 1,000 words, and sometimes a patient is more motivated by actually seeing the disease process itself, as opposed to this a number like their cholesterol and their blood pressure. I think of all the risk factors, the patients in the United States as well as their physicians have really been probably most focused on the cholesterol level, and perhaps, unfortunately, at the expense of not giving adequate attention to the other risk factors, such as the blood glucose level, or in particular the blood pressure, realizing that hypertension really is the leading cause of death globally. But yet, sometimes the patient, all they might think about is their cholesterol level. But I think what's extremely important is that a patient really be educated to know actually all their numbers and what the numbers mean. So this is extremely important. They need to know not only their cholesterol, including their LDL cholesterol and the actually good HDL cholesterol, but they also need to know their blood pressure. They also need to know their glucose and their body mass index, and kind of where they fall within recommendations for a heart healthy diet as well as physical activity. So I think extremely important that a patient really be educated to know all their numbers, because it's really the comprehensive cardiovascular risk profile that's ultimately going to determine your risk of developing a cardiovascular event. We certainly certainly know from genetic studies that gain-of-function mutations of PCSK9 are associated with very, very high LDL cholesterol levels, and conversely, loss-of-function mutations are associated with very low LDL cholesterol levels. So if we have therapeutic interventions such as the PCSK9 monoclonal antibodies, and there is even what we call what's now in development, something called actually RNA interference therapy, which actually prevents the production of PCSK9 to begin with. We now have these therapeutic strategies that are physiologically consistent with a process of regulating LDL receptors and their ability to process and destroy LDL particles.